I am going to go ahead and introduce our speaker for tonight, who is Emily Brown. She's a certified genetic counselor in advanced lipid disorders clinic at Johns Hopkins, graduated from the University of Maryland genetic counseling program in 2014, and has had the pleasure of working with patients and hereditary heart conditions for the last 9 years. She's involved in both research and clinical care and has the opportunity to present both regionally and nationally on hereditary dyslipidemia. She is co-chair of the Cardiovascular Genetics Special Interest Group for the National Society of Genetic Counselors and previously served as the chair of the Dyslipidemia Working Group. So, Emily, we've been asked by multiple people to have a talk on genetic testing and who, what, when, why. So we look forward to your talk, and I'm going to turn it over to you.
Well, thank you. And thank you for that kind introduction and the opportunity to speak tonight. So as Jan mentioned, I'm really going to do kind of a crash course in genetic testing for dyslipidemias. But I really encourage questions and discussion. I know there'll be time at the end, but as we go along, feel free to put questions in the chat as well. So these are my disclosures. So the first part of the talk, I'm going to go over familial hypercholesterolemia, or FH, and I'm sure many people, if not everyone on the call, is very well versed in this condition, but I wanted to focus not specifically on kind of the 4 main core genes that are well known and well studied with FH, but some of the causes when that genetic testing comes back negative. Then we'll also spend a little bit of time talking about the genetics of hypertriglyceridemias and then Lp(a) at the end. So as I'm sure everyone is aware, FH is the most common hereditary monogenic heart condition. It's about 1 in 250 for the heterozygous form. Typically, it's recommended to suspect it in adults whose LDL-C levels greater than 190 and children with that LDL-C level over 160. Some patients will have physical findings like the xanthomas, which you can see here in the image in part A and B. You'll see sometimes xanthelasmas and then corneal arcus, which is highlighted in the part D picture. But of course, not everyone will have physical findings, especially if someone's been on treatment for a long time. The reason why it's so important to diagnose this condition is that individuals with FH have a much higher risk for coronary disease. Men have a 50% chance of coronary heart disease by age 50 if it goes untreated, and women have a 30% chance by age 60. So the main genetics are due to a mutation in one of 4 genes. 90% of people will have a mutation in the LDL receptor or LDLR gene. And then probably about 5 or a little bit more than that, 5% or so, have a mutation in ApoB. And this is the ligand for the binding to LDLR. A small percentage, it's pretty rare, are going to have a mutation in PCSK9, and then it's extremely rare, but there is an autosomal recessive form where it's due to pathogenic variants in LDLR AP1. Majority of the time, this is actually autosomal semi-dominant. Most people think of it as autosomal dominant, but in technical genetic terms, we would actually call it semi-dominant because you have a more severe form as homozygous, but the heterozygous individuals still express a phenotype. In 2018, the American College of Cardiology came out with guidelines regarding when to do or when to offer genetic testing for FH, and they really focus thinking again about those LDL-C levels They recommend it for children with a persistent LDL-C over 160 when they have a family member or are adopted. And men, or not men, adults with an LDL-C over 190 persistently, again with that family history. But I do want to point out that they do recommend testing when people's cholesterol levels are a little bit higher, kids at 190 or greater and adults with 250 or greater, even in the absence of family history. So we know there are de novo cases, but also, it's not uncommon for family members to not share this history with each other, or just to be estranged. So even if there's no known family history, if your patient has persistently elevated LDL-C levels, I would encourage thinking about genetic testing. I often get asked, why should we do genetic testing for FH? And there's a few different reasons. But I will say that genetic testing for FH isn't the right choice for everyone. There are obviously some patients that clearly meet the clinical criteria. You see the clear pattern in the family. For them, genetic testing might not be the right option, but it can be helpful, even if it's not helpful for the proband. If they're wanting to do cascade screening in the family, they might have a child that has an LDL of 140. Well, if we then do the genetic testing, that really helps with the ambiguity of their LDL-C level. But a big reason we use it in our clinic is increasing the diagnosis rate. So a lot of patients that we see don't meet the clinical criteria using the Dutch Lipid Clinic network for FH without the genetic testing. And part of that, I think, is because the DLCN criteria weigh heavily on physical findings like xanthomas, and a lot of patients are going to have been moderately treated for a while, and so those xanthomas may not be there. And without the physical findings, it's hard to meet the criteria for a definite diagnosis. But another benefit is really knowing the risk assessment for heart disease. And this table here on the right does a nice job showing that even patients with only mild elevated LDL levels, if they have a pathogenic variant or a mutation associated with FH, they are at higher risk for heart disease compared to the general population. So even someone with an LDL-C of 130 or less, they have a 2.2 odds ratio for coronary disease, which is significantly higher than the reference population. As I mentioned earlier, the phenotypic overlap and confirming the diagnosis, that can definitely be helpful for people kind of with that gray zone LDL levels or where you're not quite sure. And we have seen it be useful in some cases for medication authorization. That's especially true for the homozygous FH if you don't have their untreated levels available. I wanted to kind of brighten up the presentation by talking about a family we saw a couple of years ago that I think really exemplifies these points. So this was a 12-year-old girl who was seen in our pediatric lipid clinic. She was originally seen at 18 months because her two older brothers had this combined phenotype of high triglycerides and high LDL. At 18 months, her LDL-C was 187. She had normal triglycerides. And then we saw, her periodically throughout the years, and her LDL decreased to around 150 until about 11. And at that point, it crept back up to 183. Again, the triglycerides stayed normal, so a little bit different than what we were seeing for the brothers. And so there was a question of, does she have FH? And maybe the brothers have FH too, and the triglycerides are related to something else. Or does she have maybe an unusual presentation of familial combined? What was really driving her hyperlipidemia? And when I saw the family, I took the family history. So you'll see here her two brothers had hyperlipidemia. Dad had known high cholesterol and high triglycerides. His triglycerides were in the 200s. Mom told us she had normal cholesterol. When we actually got a lipid panel in front of us, she had an LDL of 140 or so, normal triglycerides. And then on either side of the family, there was at least one grandparent with hyperlipidemia. So not, this is pretty common for what you would see and what you would expect for an autosomal dominant or a familial form. But we sent genetic testing and she came back with a positive result. So she has a pathogenic or likely pathogenic variant in LDLR. And with that information, we then went ahead and did cascade screening in the family. And I think this is where it got quite interesting because mom is actually the one who tested positive. And we were all expecting, of course, dad to test positive. His LDL was 177. Mom was so surprised, she insisted on paying again for her sample to be rerun at the lab. As an aside, I don't recommend this. The lab was very confident. They hadn't mixed up the samples. They do always check for gender or sex. So they knew the female sample in this family had the mutation and the male sample, dad's, did not. But this is just a really great example of where we don't want to assume, because if we had assumed, we would have missed mom actually being positive. Based on these genetic test results, we had both of them come in to clinic. And on physical exam, mom did have tendon xanthomas, surprisingly. And the physician started her on a statin. She did meet clinical criteria for FH based on the genetics and the exam and the lipids. And then dad was diagnosed with familial combined. And then we went ahead and did some further segregation, and maternal grandma actually had very clear FH. So it's a really good example of the variable expressivity, or the just variable way you see the LDL levels. Grandma's was in the 200s. She'd actually been followed by cardiology for years, and it just never been picked up because she was being followed for valve disease. And then her two brothers, so the proban's two brothers, tested negative. So we think they probably have more of that familial combined phenotype like we saw in dad. But sometimes the genetic testing isn't that nice, where you get that clear-cut answer. We know there are patients and families with definitive or definite FH based on the Dutch Lipid Clinic Network criteria who have negative genetic testing. And when you then look at people that maybe don't have as many points, have 6 or 7, 8 points, that yield goes down to 25 to 30%. So clearly there's missing heritability with that 4-gene panel. And when the guidelines came out in 2018, they did address this, and they talked about reasons why we may have missing, kind of that missing heritability. And so I'm going to go through a few of those in the next few slides. The first one is as yet undiscovered genes. And I've kind of taken that to talk about hidden mutations within discovered genes. I will say exome sequencing, which is looking at all 20,000 genes in your body, has not found undiscovered genes as of yet to be related to FH. So we don't typically recommend that approach when you have negative genetic test results. But what the literature and research has shown us is that genome sequencing, so actually sequencing the whole gene or the whole of those 4 genes, may be fruitful. And I wasn't sure how much kind of background everyone had in genetics, so bear with me if this is feeling very redundant to your background knowledge. But you probably recall from your genetics courses that genes are made up of exons and introns. The exon is the part that becomes translated into the protein. The introns are spliced out. And so in the mature RNA, you just have the exons, and that's where the majority of mutations are. But there are known mutations within the introns. The difficulty is that the current testing technology doesn't read those introns, at least very far into it. It will read a few base pairs in to look for splice site variants that are going to tell the body to splice or cut out the introns in different locations. But for example, this paper was talking about a variant they found 200 base pairs in from the exon. That's not going to be typically picked up in any of your current panels unless you were to order whole gene sequencing. The difficulty, and one of the reasons why this isn't done often, is going to be the interpretation. So these authors looked at 909 patients with FH and negative genetic testing, and they found 79 deep intronic variants that weren't in the controls. And they were only able to then prove 1 out of those 79 were pathogenic. And they were able to do this, one, by segregating in the family and by the variant frequency, but also because this specific variant, 200 base pairs in, what this diagram is showing you is actually, it created a pseudo exon. And so these individuals added in 132 base pairs within their LDLR gene. But that is a very special case. Often we don't get that lucky with what these variations within the introns do. Another cause to think about when your patients come back with negative FH testing would be the phenocopies, such as cytosterolaemia, which is an autosomal recessive form of high cholesterol due to mutations in ABCG5 and 8. It's due to the body having trouble with regulating the sterol absorption and breakdown. Then you have LALD, or lysosomal acid lipase deficiency. This is another recessive form. I tend to think of it mainly when patients also have unexplained fatty liver disease or elevated liver enzymes persistently. And then the last gene that I would put in this category is ApoE. And there is a well-known deletion within ApoE that causes some people a phenotype that really mimics FH. Some people it's going to mimic more familial combined, where you have the high triglycerides and high LDL levels. And for some people, they'll even have like hepatosplenomegaly and some other features as well. So in our clinic, what we've started doing recently, or I would say over the past year or so, is offering patients who come back negative for the 4 main FH genes the option to reflex. And I just recently pulled this data. So when we looked at, we had 265 patients that then underwent genetic testing for cytosterolaemia. We didn't find anyone who had cytosterolaemia. We found 1 carrier and 1 VUS. We had less patients do the ApoE testing. So of the 88, we had 1 positive. And then a smaller portion for the LALD. That's mainly just because I only offer that gene usually if there's features like the fatty liver disease that would make me think it's a possibility. If they just have isolated hyperlipidemia, I don't usually look for this. But we did not find anyone with LALD either. So it's a small percentage of where this is positive. But one thing I'll point out is that there's also a low rate of what we call variants of uncertain significance, or a variant where we don't know if it's causing the high cholesterol or not. And that is actually different than what we see with other cardiac conditions. So, for example, hypertrophic cardiomyopathy, when they looked at expanding the gene panel, it increased, at least doubled the variant of uncertain significant rate that they had. And we don't see that here. The one patient that I saw who was a carrier for cytosterolaemia, he actually had a loss of function variant in ABCG5. And this is actually significant beyond being a carrier, because what Amit Kara's group has shown is that heterozygous loss of function variants in ABCG5 alone are associated with an increased risk for coronary disease and increasing the LDL-C levels. So this likely was explaining, at least partially, his phenotype. These variants are rare. When they looked at the UK Biobank for patients with coronary artery disease, only 34 of 29,000 cases had a loss of function in these. So it's not going to be a common result you get back, but if you do get it back, it is significant. And they did not see the same correlation, interestingly enough, for ABCG8. So as I mentioned, it's a low yield, but we do offer it. And for the families that it does find the answer, it does provide some guidance and the option for cascade screening. Okay. And then the last one I wanted to just touch on is polygenic form of hyperlipidemia, or even of FH. So rather than the monogenic, the form that's due to lots of small variations within many genes that add up to cause hyperlipidemia. So just as a crash course, and this is by no means going into all the details, but I wanted to just briefly touch on how a PRS is developed, or the polygenic risk score. So typically what happens is they take data that's collected from the genome-wide association studies, or GWAS, and you have cases and you have controls, and you look at what variations within the genes are seen at a higher frequency in the cases than controls, and you can then weight those based on how strong of a factor you think each variation is. And so it's put into an algorithm. And then typically what happens is that algorithm is going to be validated in at least one other cohort to make sure that it's accurately predicting who is at high risk, who is at, maybe medium or kind of average risk, and low risk based on those specific variants that have been pulled up. High polygenic risk scores are actually quite common. They're more common than FH. Amit Kara's group has done a lot of work in this area. When they looked at, for example, 100 patients with early myocardial infarction, only 2 had FH, whereas 17 had a high polygenic risk. So you're going to see it much more frequently be the answer. Similarly, when they applied a polygenic risk score to the UK Biobank population, 8% were at that high threshold of having 3 times the risk. So it was 20 times more common in the UK Biobank than FH. So there is the potential for polygenic risk scores to really be far-reaching and be informative for a lot of patients. So thinking about, well, what percentage of patients with FH are we missing or actually have this polygenic form? There's a few different studies that have looked at this. This study that came out in 2019 looked at 626 individuals with either possible, probable, or definite FH. As you would expect, those with definite, based on the DLCN, were much more likely to have a positive monogenic form, but the probable and possible, you had about 25 to 30% of those people with a high polygenic score. And then this paper that came out a year later in 2020 looked at patients with FH who had a known pathogenic variant, but maybe, well, they divided it into either people that had coronary disease or did not. And those that had coronary artery disease were much more likely to have a high PRS in addition to the monogenic variant. So you can see this start to explain some of the variable expressivity within some of the families and between families. And going back to that first paper, when they looked at that variable expressivity piece again, they found individuals with combined monogenic variant and high polygenic risk again had a much higher risk for heart disease. But I do want to bring up a few caveats with this. One major limitation right now is the diverse population. So often the polygenic risk scores are developed within using genetic information from European cohorts, and that's mainly due to a lot of studies previously being done in mainly European cohorts. It is getting better. So you can see with the pie charts on the right that back in 2009, 96% of these GWAS studies were European ancestry, and it's gone down to about 81%, at least as of 2016, and that should be have improved even further. But the difficulty is when it's done in a European cohort, it may not be as accurate when you're looking at someone with a different ancestry. And it can be because the variants are seen at different frequencies, where one variant in a European cohort might look rare and significant, but then when you apply it to, say, a Latino cohort, it might be really common. And so you might not have that same significance on it, and you could be doing an error in calculation. Additionally, one of the tricky things with a PRS is it's not necessarily pinpointing a gene that is related to the higher risk, but an area. So if there's linkage disequilibrium, or the area that's been highlighted in the European cohort has genes that are different around that area than in the African American cohort, you're going to see errors in calculation. So it's really important that these PRSs are validated across cohorts before you apply them, and you definitely want to make sure that it is applicable to your patient's demographic information. Currently, there's really limited access to PRSs that have been validated for a clinical setting. There are some options for research, and I know some institutions have their own that they've developed, but right now there's not a lot of options just in general for it. You also want to think about, when you're thinking about the PRS, the idea that there's missing heritability. So a polygenic risk score is only going to cover, maybe it could cover as little as 10% of the heritability of a condition. So you're only explaining a small part of why someone has high cholesterol or coronary artery disease. And you want to look at the technology used and then the area under the curve, or how well it discriminates between people with coronary disease or that high risk and low risk groups. So kind of overall for FH, when it's negative, I would recommend thinking about phenocopies. Is there further monogenic testing that's useful? Think about a polygenic risk score, at least keep that in mind for the future. And then the possibility, is there a deep intronic variant or unknown genes? All right, so I am going to go through now hypertriglyceridemia, probably in the next few minutes, and then I'll end with LP(a). So as everyone on the call knows, there's lots of different causes for high triglycerides. And usually it's not going to be solely genetic. Often it's going to be a combination of things. But of course, there are a small portion of patients with severe monogenic hypertriglyceridemia. And Dr. Hagley's group in Canada has done a lot of work in this regard, and they found that probably about 1% of people have that severe familial chylomicronemia syndrome, or type 1, where it's recessive and it's due to mutations typically in LPL, but there are other genes associated. Majority of people are either going to have, again, either a polygenic or it's going to be autosomal dominant with a second hit, like pregnancy or uncontrolled diabetes, certain medication exposures, things like that. I think probably most people would pretty easily identify the type 1 because it's just such a striking presentation. The triglycerides are over 10,000. You have recurrent pancreatitis because of that. Usually it's going to be a childhood early onset onset. And you can see the physical findings too of eruptive xanthomas, lipemia retinalis, and neurological symptoms. And if you draw these patients' blood and let it sit, you'll actually see that fatty layer develop on the top of the blood. But so I don't think many of these get missed just because they have such a severe presentation. But I think the part that can get missed pretty commonly are going to be those autosomal dominant forms that are moderate. And this is work, again, from Dr. Hegley's group that looked at that. And so the first two outer rings are patient samples, and then the inner ring is a case or a control cohort. And what you can see is that maroon section are people with one heterozygous variant. And within the patient cohorts, about 10 to 15% did have a heterozygous variant. And then we assume that second hit that really led to the development of the hypertriglyceridemia. And just to exemplify this, I wanted to go through another case quickly. This is a 45-year-old male who was actually diagnosed at 18. We didn't see him in our clinic until his 40s, but he reported this history, no known history of pancreatitis. The highest triglycerides we had were 735. At that point, he was put on rosuvastatin, and that's when we saw him in our clinic, and he had an ApoB of 103, and the Snyderman algorithm gave him a type 4, but there was a question of, was the rosuvastatin really skewing how the algorithms determined his phenotype? So we sent genetic testing. And here's the family history. Not really remarkable. Dad had hypertriglyceridemia, but he didn't know how severe, what the levels were. He didn't think any pancreatitis. And so we sent the genetic testing. Typically what I'll send are the five main genes associated with the hypertriglyceridemia. Some labs also include a 6-gene GPD1. But he actually came back positive for a likely pathogenic variant ApoA5. And I was actually surprised by this because he didn't have a super severe phenotype, no pancreatitis. But it just reinforced for me the value of testing in this field, even when it looks, like it's probably going to be negative, because this then had important implications for his family and thinking about their risks. Okay. And then coming down the pipe is therapies. So there are ASOs being developed that specifically target these genes and will hopefully help with treatment. And for that reason, genetic testing, I think, will become even more important for these patients. Okay, so that was a very quick and dirty few minutes on hypertriglyceridemia. And I'm going to have a little bit of time here on Lp(a). So lipoprotein A, as I'm sure you guys are all aware, you have the LDL-like particle along with apolipoprotein A. A key part of this is the Kringle domains, especially from a genetics standpoint. The heritability of Lp(a) is thought to be around 90% based on twin studies. And so that's a little bit different than LDL because diet and exercise really are going to have minimal impact here. And it's quite common, 1 in 5, so 1 in 200 individuals are thought to have an elevated Lp(a), at least using the cutoffs that this study used of 100 nanomoles per liter. And of course, it's also common for someone to have FH and also an elevated Lp(a). The genetics of Lp(a) are much more complex than FH. So where FH is this very simple, nice model of monogenic disease, LP little a doesn't play as nicely. A big portion of the heritability of it is due to the Kringle 4 repeats. Depending on an individual's ethnicity, that probably explains about 30 to 70% of the variability. And it's an inverse relationship. So the higher the number of repeats, the lower we would expect their LP little a to be, and vice versa. But of course, gender and ethnicity also play a role. It's interesting, this graph on the right shows this, that, we expect, for example, African Americans to have higher LP little a. And they do, but the number of repeats stay high too within those boxes. So you kind of see that falling across ethnicities. So as I mentioned, the Kringle repeats explain a lot, but not all of it. So then what is explaining the rest? And part of that is going to be variants within the LPA region, or that gene region, that are outside the Kringle repeats. And there's at least 20, probably more than that, that have a partial effect on someone's heritability or the genetics of LP little a for them. And this graphic on the right is just showing all the variants that have been so far attributed to this. So it's probably a combination, or we know it's a combination. You have the Kringle repeats, you have the other genetic variants which play into a role, and then you have non-genetic influences. But because of the complexity, this is difficult to do genetic testing for. And also, the Kringle repeats itself doesn't play very nicely for the next generation sequencing technology. It's more accurate to do that by, say, a Western blot, just because of the number of repeats. And so often the labs can't get a definitive answer in that regard unless they're doing a Western blot. So it just becomes complex. Typically, what I recommend is not doing genetic testing for LP little a, but rather just screening family members by their serum concentration, because it tends to be so stable. It's not something you need to continually repeat, and it's a pretty easy way to screen first-degree relatives of anyone with significantly elevated LP little a, and much cleaner than at least the current genetic testing is offered. And I wanted to wrap up with this nice infographic that came from the FNLA's genetic testing and dyslipidemia guidelines that came out a couple of years ago, that just walks through when to consider genetic testing. Can be helpful in a variety of different avenues. And I wanted to lastly just acknowledge that I know there aren't genetic counselors everywhere, and I hear from people frustration pretty frequently that they would like to use a genetic counselor in their clinic and they're not around, or they only specialize in cancer or prenatal. The pandemic, I would say one silver lining is the pandemic's helped with that in terms of telemedicine. So if you can find, a specialty center, their genetic counselor might be licensed in the surrounding states. I know that is the case for myself at Hopkins. I'm licensed in the Mid-Atlantic and Florida and some of these other states on the East Coast. But also the FH Foundation does have a nice Find a Specialist button, or the Family Heart Foundation, excuse me. So that's a way that you can also look for a genetic counselor. But also, if you're struggling, please feel free to email me. I do know a lot of the cardiac counselors in the country, and so I may be able to connect you with someone if you're having trouble. And with that, I wanted to just open it up for questions.
Oh my gosh, Emily, that was awesome. I appreciate that. Was really a great overview of FH, hypertriglyceridemia, LP little a. It gave us a little bit of a mix for everything. I'm gonna have those who are currently on the webinar. You can either open up your microphone and ask your question in person, or you can put your question on the chat, and I'll read it out to Emily. But I think one of my major questions is, for those of us who don't have genetic counselors, as you were mentioning before, not everybody does. I don't have a genetic counselor available to me. I am a lipid specialist and essentially spend my entire day treating lipids. What is kind of like a general clinical pathway for, so I would assume if you have a patient coming in with an LDL greater than 190 or someone coming in with hypertriglyceridemia, kind of what is the basic working? Do you start out doing genetic testing right off the bat or what?
Yeah, so in our clinic, usually the patients will have a meeting with the physician, an appointment with the physician first, and then the physician will refer for genetics after they've had a chance to talk with the patient. But we are pretty, I would say, generous in who we offer genetic testing to, because we have found patients with, for example, ApoB mutations that really only have an LDL of 160 or 170. So, if they're young and fit and you don't have any other reason to think, oh, this is why they have high cholesterol, we'll often go ahead and offer it. And some patients want that testing and others don't.
Excellent answer. And that actually leads us into a couple of questions that are on the chat. What are the companies that offer genetic testing, like LabCorp, Quest? Can you send your patients to these commercial labs? And does insurance cover it? And what is the cost? Yeah. And is each company a different variant, or is there one-stop shopping that you can get everything at one place?
Yeah. Oh, it's a good question, and it's complicated, right? So every lab is a little bit different, especially in regards to insurance. But for example, LabCorp and I think Quest do offer FH genetic testing. Think it's just for the 3 most common genes. So it's just for ApoB, PCSK9, and LDLR. There are other genetic testing companies that I would say are probably more frequently used by genetics providers. And the main ones, there's Invitae, there's Ambry, there's GeneDx, there's GB Insight, there's Prevention Genetics. And which lab you use is partly going to maybe depend on your patient's insurance. So certain labs are in network with other, with certain insurances. Sometimes it can come down to what the out-of-pocket cost is. Some labs offer patients a self-pay price of $250, so you don't go through the insurance, and that's just what they charge as a cost. A lot of the labs do have good financial assistance programs, but it does get a little bit complex, especially with the insurance piece. For example, some of the Blue Cross Blue Shield require pre-authorization that you have to enter into their portal, and that can't be entered by the lab. It has to be entered by the provider for it to be approved. So they've made it a little bit tricky.
Good to know. Great information, because certainly providers need to know what their responsibility is if they're going to order it. Now, what about, I know at one point in time, some of the labs offered their own genetic counselors. So you as a provider didn't have to have your own counselor. But some of the other labs had their own counselors that would talk either via Zoom or via telephone with the patient. Is that still the case?
It is, at least for one lab. So at least Invitae does that still. And there are telemedicine companies. I should have mentioned this. So like Genome Medical is fully telemedicine based counselors that can see patients anywhere in the country. So if you personally don't want to kind of deal with all of this or don't feel confident in this area, that's definitely another route to go if you don't have access to a genetic counselor locally.
Okay. I know for some point in time, a lot of individuals, and certainly this was more regional or state based, had issues getting some of the newer cholesterol lowering therapies approved if they did not have genetic testing or a certain score with genetic testing. Has that eased up a little bit through the years? Do you know? Is this something that you heard of as well?
So I have seen that, and we did see it more commonly especially when the PCSK9 inhibitors came out. That was definitely a reason that I was getting referrals. And talking with our providers, that's eased up a little bit. So, it's not always necessary, even if someone doesn't meet criteria, for them to have the genetic testing.
Okay. So, wow, you've given us a lot of information. I appreciate you speaking. I have asked all the questions on the chat, and I see, Emily, you gave out your email address. So certainly anyone who has questions that they may want a more personal one-on-one answer from Emily, you can see the email address right there. If anybody else wants to verbalize their question, you can certainly open up your microphone and ask Emily yourself, or once again, send it through the chat. But I think this was a fabulous discussion and great information. I think one of my most difficult patients right now in clinic is the hypertriglyceridemia patient, from a triglyceride level of 300 to 2000. And so definitely a lot of information that you were able to give us in order to better treat these patients.
Yeah.
So I do not see any more questions. Do you have anything to say about those patients in clinic that come in?
Yeah, I would just say I think genetic testing can help. I at least have been surprised sometimes with the triglyceride levels and the variability that we see for patients with positive genetic test results and how it can fluctuate so much.
And so how does that change therapy?
So it doesn't really change therapy right now, except for clinical trial participation potentially. The main thing from my perspective is thinking about family members who also carry the variant and maybe haven't expressed the hypertriglyceridemia, because you're going to be more careful about, say, like what birth control they might use or other medications. If they have diabetes, really, talking about controlling the diabetes and things like that.
And certainly prevention of pancreatitis.
Correct. Yeah. And it does answer the question potentially clinically of what's driving this, which, depending on the provider, I know can be more helpful for some people to have that answer than others. And sometimes the patients then feel like they can reach out to like FCS Focus or get the support because they have a definitive diagnosis too.
Excellent. Well, Emily, it looks like we're coming close to the end of our time. I do appreciate all of this information. Certainly, all the recommendations for you are very warranted. You did a great job. We appreciate it. I'm going to give everybody back a little bit of their time. We appreciate you taking time out on your Tuesday evening. If anybody ever has any recommendations or a subject matter that they want addressed during the CLS Speaks webinar, certainly reach out to me and I will get a speaker and take care of that. Otherwise, I hope everybody has a great Tuesday. Once again, be on the lookout for upcoming NLA emails. And Emily, thanks again. Appreciate your time and great slides.
Thank you so much.
Bye, everybody. Have a good evening.